Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ. I am Dr. Arshan, as most of you know, and let me welcome you to our 2 weeks free session. So you guys are aware of that we are going to start our 5 months new course, and basically today is our first class of that 5 months course. And that says that you are actually doing our course, but we offered the opportunity to see how the course usually occurs, how we take classes, and that's the reason why everyone gets this 2 weeks free session. And then you can decide if this course is helpful for you and if you want to get enrolled. Now, you might be able to see in our Facebook group that in October, I think about 14 to 15 students passed from our course. So if you see that just in 1 month, we have got 15 students. And I think like maybe 1 or 2 reappeared, but almost 90% they were in the first time attempt candidate. So you can see that how good the result is from our course. And it's not just October. Throughout this year, we have achieved this much amount of students almost every month. So you can rely on us, especially on MCQ, theory, and also question solvation. You might be able to see our course details, and you can see that the course has everything that you need to pass this exam. We will go through the course detail again at the end of the class, but if you guys have got any questions, anything that you are not sure about, you can always ask me now or at the end of the class. Okay, now tonight's session is mainly focused on a very important topic, which is tips and tricks of solving questions. When you start preparing for MCQ, 2 things is main. One is having a good basic of your theory knowledge. That means you need to have some idea on specific topics that is important for your exam. Now, a person can read everything, but what will happen is that everything will get very confused at the end. If you don't know what is important for the exam, trying to follow, that preparation is never ever going to give you the expected outcome. Okay, so to get the outcome as you want, you need to have some guidance. And we have been preparing our students for the last 5 to 6 years. And every year we have achieved a huge success. And you might be able to see that we are one of the best in Australia. This is an Australian registered course. And you can also use this course as a bridging course so that you can show it when you need for any kind of registration in here. Now, First Aid AMC MCQ has to offer a lot of things for you. It's not just taking the classes and then just finish the course. Our main objective is not just making sure that you are getting into the classes or the course. Our main intention is to be with you until you start working in Australia. So we have everything. You pass MCQ, then you have our clinical course. We have our job searching classes. We have registration pathway classes. Almost everything that you need to start working in here, you'll get it. So this is just the start of your journey in here. As I was saying that when you start preparing for MCQ, you need a good basic on theory, which will be covered in our class. And also you need to solve questions to have some idea how the questions can appear in your exam. Solving questions is a very important part of your AMC preparation. You might have a good knowledge on theory, but sometimes the questions becomes very tricky. If you don't solve those, you might not be able to answer it properly. Even though you know the answer, you will pick something wrong in the exam. So the type of the question, the tips and tricks are very, very important to understand. Initially, you will get confused. Initially, you will feel very overwhelmed. But that's the time where we help you to understand where you don't need to get confused. When you start solving questions, you will find out like sometimes questions are very short, sometimes question does not have enough information, sometimes question does not make sense. So everything in a question has something meaningful. Either it's a trap for you so that you pick a wrong answer in the exam, or those are some tips or tricks so that you can get your correct answer in the exam. So if you can understand what's the trap and what's the tips, you most of the time you will be able to pick up the correct answer. So that's where we are going to discuss tonight, that how to solve questions properly and how to find out the traps in the exam. All right. Okay, so let's just start. I can see that some of you are also in Facebook. Now, if you are in Facebook, what you can do that if you have any answer, you can always, if you have any question, you can always just write it in the comment section. And now I usually just go and see if you have any questions and I can always answer you. But to remember one thing, that our classes always happen on Zoom. Never we take classes on Facebook. This is just for this 2 weeks free session. I know that some of you have difficulty to join the Zoom session, just for that. But when you start our course, the classes will be on Zoom. So if you know how to use Zoom, come and join the Zoom sessions. The class ID and password is already given in your Facebook group. So it becomes easier for you to talk to us in here, because I can't answer your questions directly on Facebook. But if you are here in Zoom, you can always even unmute yourself and ask questions directly. But during the class, what we normally do is to keep you muted so that there is not much of a noise in the class. Because sometimes a new person join the session and there is a lot of sound happening in the background and class get distracted. So that's why we keep you muted during the classes, but you can always write it in the Zoom chat box, or those who are in the Facebook, you can write it in the Facebook comment section. Okay. All right. Now let's start our tonight's session. We will solve questions, random questions. That means it can be from anywhere. And random questions, we take one class every week on this random question solvation. And that covers most of the important recent topics that is very, very important for your exam. Okay, so let's start with this question. When you see a question, what you should normally look for? Look that what is the age of the patient, what is the sex of the patient, what is the main complaint of the patient. And the very important thing is that what is the question, what they're asking for. So we have got a patient, let's say it's a 50-year-old male patient. He's a diabetic with ulcer on the right foot. And the picture is given like this. So you can see that there is you can see it's a large ulcer on the foot with skin necrosis and inflammation. The HbA1c is 6.5. So patient is diabetic, but it is not uncontrolled. It is a controlled diabetes, right? 6.5 HbA1c is not too bad. He was admitted and antibiotic was given. You have taken swab, sent for microscopy and culture. What will you do after that? So your main question is that what to do next, right? So what you have done for him so far, it's a diabetic foot ulcer patient. And you can see from the question that it is mostly a severe one because skin necrosis and inflammation has happened. So they're talking about it's a moderate to severe diabetic foot ulcer. When they talk about deep ulcer with skin necrosis, which means that it's not just a mild foot ulcer, it's a moderate to severe one. In such cases, for diabetic foot, we can give them antibiotic if there is discharge and we take swab sent for culture, that's all right. But what will you do after that? Do you want to do a X-ray of the foot? You want to do MRI? You want to do bone scan? You want to do Doppler ultrasound? Or you want to check for complete blood count? Okay, I can see that most of you are in between X-ray and Doppler, right? Now, the important thing, which one is mostly important for this particular case? For a diabetic foot, which one is important to find out? Because the urgent one is that if it is a deep ulcer, and if there is a surrounding neck necrosis, surrounding skin necrosis, you're mainly worried about osteomyelitis, right? Even before vascularity, this is the most important because osteomyelitis can it's a bone destructive lesion, right? And the infection going to the bone, it can be devastating. Patient might need amputation for that. So in this case, the most important thing to find out is that if this patient has got a osteomyelitis or not, okay? So if we are thinking about osteomyelitis, what is the first investigation that we do in such cases? We do X-ray or MRI. Now, if they say that what will you do after that, they're actually trying to find out next investigation. The next investigation in such case is X-ray of the foot. Okay. Just give me 1 minute. Let me, because there is sound happening surrounding me. Let me just pause for 1 minute and then we will start. Okay. Thank you. All right, guys. Sorry for that. So what we are doing in here is that we have been discussing about diabetic foot ulcer, right? So for a diabetic foot ulcer, the most important thing that you should always try to rule out is that if this patient going to have a osteomyelitis of the foot, because that's the most urgent fact. So if we are suspecting, especially if you get a patient where question says that there is deep ulcer, skin necrosis, those are the main point or tips to think about osteomyelitis. In those situations, mainly we will first do a X-ray, but X-ray most of the time will not be definitive because many times X-ray initially will not be able to pick up osteomyelitis. So if they ask you, what will you do for diagnosis or how you are going to diagnose this patient? Or if they ask you what is the most appropriate investigation, if that is the question, then we will pick up MRI. Okay, so the question is important. If they ask you what are you going to do next or what will you do after that, that means they're asking for initial. Initially, we will always do X-ray to see that if there is bone involvement or not. If they ask you that what is good, which investigation will you do for diagnosis or what will lead you to diagnosis, those kind of things means that they're asking for most appropriate investigation or most diagnostic investigation, or you can say in a word, confirmatory investigation. In those cases, MRI will be the best option. Sometimes even MRI, if not able to pick up, then we can do a bone scan also. Okay. Doppler might be also a good idea if we are thinking about that it's an arterial ulcer. But as the patient, as in here already they have said, it's a diabetic patient. Let's not just go to something else. It could be arterial ulcer as well, but when something is given like this, like it's a diabetic patient having ulcers, think straight as osteomyelitis. Okay, what if someone would give you that there is an ulcer in the foot or dorsum of the foot or tip of the toes? It's very painful ulcer. Then we would think about possibility of a arterial ulcer. Okay, in that case, you could do a Doppler ultrasound or a arterial Doppler ultrasound. If you would think about venous ulcer, you could do a venous Doppler ultrasound. So it depends what questions actually ask. You're not going everywhere. That's the most important part. So this is how diabetic foot infection looks like. These are the stages of diabetic foot infection. In a mild situation, you will get just a local infection, which will only involve the skin, and the surrounding redness should be less than 2 centimeters. In moderate, local infection with erythema more than 2 centimeters around the wound, but also it will involve the deeper structure like more than skin or subcutaneous tissue. Severe means when there is deeper ulcer along with a systemic inflammatory response, like patient getting febrile, tachycardic, septic, then it's severe. The tips for exam for this kind of case is that if you have got a diabetic foot ulcer, which is non-healing, especially more than 2 weeks has been passed, still it's not healing at all, that is the time you are suspicious of osteomyelitis. Next investigation will be X-ray foot. If they ask you the most appropriate, then MRI or bone scan. Okay. If you get a question where they say that it's a diabetic foot, but you can see some yellowish discharge coming out from the wound. If there is a discharge, they say, then if they ask what is next investigation you are going to do, that should be a wound swab. After wound swab, what are you going to do? You're going to do the wound cleaning or wound toileting. After cleaning the wound, then you will start the patient with antibiotic. So this is the step-by-step approach for diabetic foot patient who has some discharge coming out of the wound. Or you can say it's an infected diabetic foot. In that case, wound swab first, then wound toileting or cleaning, followed by antibiotic. So which antibiotic normally we choose for such cases? For mild infection, just any of the usual one, commonly you could use flucloxacillin or dicloxacillin. you can use cefalexin or amoxiclav. In case of moderate, IV augmentin or cefazolin plus metronidazole. In case of severe, you have to control the gram-negative bacteria also, which is piperacillin, tazobactam plus clavulanic acid or ciprofloxacin. So this is the Australian guideline as well. So you will treat it accordingly. So you already know which is mild and moderate. Moderate means the skin erythema is more than 2 centimeters surrounding the wound, but there is no local systemic feature. But if there is a systemic feature, then it becomes severe infection where you will have to use 3 antibiotics, which is piperacillin, tazobactam, and sometimes either a clavulanic acid or ciprofloxacin. Okay, so that's your choice of antibiotic for diabetic foot. This is a picture from an Australian guideline, which is called imaging pathways. So imaging pathways, sometimes you can use for some stepwise approach for very important topics. So this is called imaging pathways Australia. So if you have got a patient with a diabetic ulcer, you have done plain X-ray. If the X-ray changes compatible with osteomyelitis, then you will have to do a bone biopsy followed by treating as osteomyelitis. If X-ray does not show features of osteomyelitis, then you should look for that if there is positive probe to bone. If you use a probe and you can feel the bone on that, then you should suspect possibility of osteomyelitis. Consider a bone biopsy. If it's positive, then treat as osteomyelitis. Let's say even after that, like there is negative bone probe, but you're still highly suspicious of osteomyelitis, do a MRI. Okay? If MRI contraindicated or unavailable, then you do the bone scan or nuclear medicine scan. If MRI or bone scan suggestive of osteomyelitis, you do a bone biopsy and treat the patient with as osteomyelitis. Okay, so you can see the stepwise approach. This is how exam questions come. They might say that you have already done X-ray, and X-ray does not show any feature of osteomyelitis, but the symptoms are very similar to osteomyelitis. Will you stop there? No. Then you will try the positive bone probe and see that if positive bone probe is not positive, or you can't feel the bone on probe, then still if you're suspicious, you can do MRI or bone scan. So this stepwise approach, you will have to remember for exam. Okay? Any question with this case? Okay, so I guess there is no question on this one. Moving on to next. Bone probe is kind of like, it's an instrument. You can search it from the Google. So it's an instrument, like a very, very narrow instrument, and you will try to insert that instrument into the wound, and you will try to see how much you can go in. And if you can go in and in, and you can touch the bone, which means that the wound is very deep. Okay, so that's called bony probe. Moving on to the next question, a previously fit 55-year-old man has undergone an emergency right hemicolectomy for a perforated cecal carcinoma. 2 days after the operation, you note the following on his fluid balance sheet. You have given intravenous input of 2 liter, and output happened in this way: nasogastric aspiration 2 liter, drain loss 700, urine output 500 ml. Biochemistry shows sodium, potassium, chloride, and bicarbonate. You can see potassium is a little low. Which of the fluid balance regimen below would you order for the next 24-hour period? So the basic question is that this patient is a post-operative patient. It's a second post-operative day, and they are asking for a fluid balance regimen for this patient, which means that now you're going to find out the maintenance fluid for this patient. Okay, so how to measure this maintenance fluid is a very important topic for your exam. So when you have got a patient who you need to give maintenance fluid, the first thing that you need to find out that what is the input and what is the output. So in this patient, input is 2 liter, right? And others are all output. So output, you have got nasogastric aspiration 2 liter, drain loss 700. You have got urine output 500 ml. And every patient have some insensible loss, like some loss from sweating, heat. So we keep it as 500 ml. So if you measure that, how much it becomes? So 2 liter. So it's around 4 liter. If you make it whole, it becomes around 4 liter. So as part of like just for simplification, keep it as a whole, and that becomes easier. Okay. So you have got in here that this patient having input of 2 liter and output of around 4 liter. So if you measure it, it becomes 3700 ml. Okay. So 3700 ml, you can just round it as 4 liter. So what you have got, this patient, you are giving 2 liter fluid, but output is 4 liter, which means there is a fluid deficit in this patient, right? So how much fluid deficit in this patient? Excuse me. So 4 liter output, 2 liter input. That means 2 liter is the deficit amount. Okay. If 2 liter is the deficit amount, how we are going to give this 2 liter to this patient as a maintenance fluid? That's the main question. So as a formula, remember that every patient in the postoperative period, as a maintenance fluid, they will receive 1 liter normal saline plus 2 liter dextrose plus 20 milli equivalent potassium per liter of fluid you will give to the patient. Okay, I'll come to this point later on. So this is a maintenance fluid. 1 liter normal saline, 2 liter dextrose plus 20 milli equivalent of potassium per liter of fluid. Now that will be given to everyone, but this 2 liter you will have to add in this maintenance fluid. And where do you normally add it? To the normal saline. So now it will become 1 liter plus 2 liter. So it's a 3 liter normal saline plus 2 liter dextrose plus how much potassium now? So 20 milli equivalent potassium per liter of fluid. So how much liter of fluid you are giving? 3 plus 2, right? 5 liter. So it will be 20 into 5 equal to 100 milli equivalent of potassium. Okay. So this patient will require 3 liter normal saline plus 2 liter dextrose plus 100 milli equivalent of potassium. And if you come to the answer, you can see here that option D, 3 liter normal saline, 2 liter dextrose, and 100 milliequivalent of potassium. That's your answer for this case. Did you guys get it? So the first thing you find out what is the input and output, and then you find out what is the deficit of fluid. If there is a deficit, you will have to add it to the normal maintenance fluid. Normal maintenance fluid is 1 liter normal saline and 2 liter dextrose. The deficit amount will be added to the normal saline. So previously you just gave 1 liter. Now you will have to add 2 liter with that. Becomes 3 liter normal saline, 2 liter dextrose, and 20 milliequivalent potassium every liter of fluid that you are giving. You are giving 5 liter fluid, so just multiply 20 by 5. Okay. Actually, this will not take this much time because when you know about it, it does not take even a minute. But when I'm explaining, it takes a lot of time. Sorry, guys, I think I just got muted. All right. Yes, normally 1 liter normal saline and 2 liter dextrose, this is given in a patient who has some hemicolectomy or like a very serious kind of operation. Like you can see it's an emergency hemicolectomy patient for a perforated cecal carcinoma. For an urgent emergency case, yes, this is how you will give fluid to the patient. And obviously this patient will not be able to eat at this time. So you'll need to maintain the fluid in this patient, not for everyone. Okay, like for someone who is able to eat and drink, they don't need postoperative fluid after 2 days. But for someone like this patient who will not be able to eat, yes, you will need to give them fluid. Okay. And this is from Australian guideline. I think it's from the T. Jandra surgical book. T. Jandra is one of the book that you can follow for surgery. Not much important, but this formula that we have discussed, it is from T. Jandra. Okay, and the output is very easy to find out. It's a nasogastric aspiration 2 liter, drain loss 700 mil, urine output 500 mil. So 2 liter plus 700 mil plus 500 plus there is another 500, which is an insensible loss. The loss of fluid that happens usually from everyone, but you can't see it, like from heat, from sweating, those kind of things. If you add it, it becomes 3700 mil. We make it whole, that's 4 liter. Okay, so that's the output. Moving on to the next question. A patient coming back from Thailand with history of having sex with multiple prostitutes. After 1 week, presents with lymphadenopathy, mild pharyngeal erythema, splenomegaly, sore throat. There is atypical lymphocytes present. Mono spot test is negative. What is your diagnosis for this patient? So patient coming back from Thailand, history of having sex. After 1 week, patient having symptoms of lymphadenopathy, pharyngeal erythema, splenomegaly, sore throat. Also, you have got atypical lymphocyte. Monospot test is negative. Now, a lot of traps are here. If you know this kind of question, you understand how many traps they have given in here. Okay. If you are not very confident, you will obviously get it wrong. The first thing that they have given you as a trap, that anyone who is beginner or new will think that after having sex with prostitutes, HIV is the most likely cause. So they will pick HIV. With the other hand, atypical lymphocyte can be found in HIV patient, can be found in EBV patient. But monospot test is mainly positive in Epstein-Barr virus. In 60% cases, monospot test will be positive in infectious mononucleosis or Epstein-Barr virus infection. But in other 40% cases, it might be negative. So that means that if monospot is negative, it does not rule out Epstein-Barr virus. Okay, so don't get confused in this way. So you can see that a lot of traps are already given. If you are not sure, you will get confused. Even before we answer this question, this is from your JM. In John Murtag, you will be able to get this kind of table, which is the table 28.1. If you look at here that how to differentiate between EBV infection and HIV, you can see that EBV takes a little bit time, insidious, HIV acute infection. Fever can be there in both, fatigue common in both. Now, the main feature of Epstein-Barr virus infection is sore throat and causing tonsillar hypertrophy with exudative pharyngitis. So patient will have sore throat, which is not very common in HIV infection. Maybe a mild enlargement, but pharyngitis is very unlikely, rare. So if you come to the question, you can see this patient having pharyngeal erythema and sore throat. When there is sore throat, our direction usually goes towards Epstein-Barr virus infection. Whereas a mucocutaneous ulcer, like oral ulcer, is very common in HIV. Jaundice can be there in Epstein-Barr virus infection. Diarrhea common in HIV. Cervical lymphadenopathy common in both. Whereas hepatomegaly, splenomegaly is common in, like, not very uncommon in Epstein-Barr virus, but it's very rare in HIV infection. Which comes to our question again. You can see that this patient has got lymphadenopathy and splenomegaly. When you have got sore throat and splenomegaly, our direction is towards Epstein-Barr virus. Okay, so that's how you're supposed to rule out these two important findings. You can see atypical lymphocyte, 80 to 90% cases in Epstein-Barr virus, less than 50% in HIV. So lot of symptoms are very similar in here, right? So what you normally need to do is that just think which one is common and which one is in your question. If same question coming to you with lymphadenopathy, fatigue, oral ulcer, and patient having just mild pharyngeal erythema, no sore throat, no splenomegaly, then you might think about possibility of HIV, which they do in the exam. In exam, maybe you have solved a question, and then they can change the question in a lot of ways. Like, as I just said, that this question, Epstein-Barr virus is your answer. But if I cross splenomegaly and sore throat from here, the answer becomes HIV. So that's how you will have to be very careful in the exam. Do not think that you might have solved a question and it looks similar to that question, does not mean that it's the exact question. You have to be very careful about this kind of traps. Always make sure that every question is new. Every question you will have to read properly to answer. Okay? CMV is not a very common infection. On the other hand, you can see that tonsillar hypertrophy, exudative pharyngitis is also uncommon in CMV infection. Even cervical lymphadenopathy is uncommon. Hepatomegaly, splenomegaly can be there. Atypical lymphocyte can be there. But our patient does have tonsillar problem, right? So that's why it's not CMV infection. In JM 8th edition, you should be able to find it out in the infections chapter. There is chapters of baffling bacterial infection, viral infections. In those chapters, you will be able to find it out. We will also do the theory sessions on these chapters, so you should be able to find it anyway in those classes. Cool. Moving on to the next one. A man coming back after short trip from endemic area for only 5 days with severe jaundice. There is fever. On examination, you find that patient having tender liver, which is enlarged 5 centimeter under costal margin. You do investigations and you have found very high ALT, AST, GGT, and ALP. What is your diagnosis? So endemic area, short trip for only 5 days. Patient has got severe jaundice, fever, tender hepatomegaly. So fever, jaundice, tender hepatomegaly, and also you have got very high ALT, AST. So are you thinking about viral hepatitis A, Hep B, malaria, infectious mononucleosis, choledocholithiasis? You can forget about choledocholithiasis because it does not give you fever, because it's just a biliary stone. So forget about this one. Then you have got all others. Let's think about one by one. Infectious mononucleosis should have come to you with some sore throat, okay? And it does not give you tender hepatomegaly. It can give you hepatomegaly, but tender hepatomegaly is not usually the feature. Malaria is a very, very important thing to rule out here. But the main thing is malaria giving you very high ALT, AST, tender hepatomegaly is not a common finding, especially not the acute malaria. If it's a chronic malaria, yes, it can give you hepatosplenomegaly, but for acute cases like this, we are not thinking about malaria. The main thing is that this patient has got very high ALT, AST, and tender hepatomegaly with jaundice. Our diagnosis should be hepatitis. Now the question is, are we talking about Hep A or Hep B? Whenever they talk about an endemic area, they're actually talking about something which is fecal-oral route, because Hep B is never ever endemic, but Hep A can be endemic. So, and also for hepatitis B, they would give you some clue that patient might have some blood transfusion, maybe some tattooing, maybe he or she pierced the nose or ear. So something blood-related transmission should be given in the question, or maybe sexual. So either sexual transmission or blood-related transmission, if it was there, we could think about Hep B. If not, then we would think about acute viral hepatitis A. Okay. If you get tender hepatomegaly in the question, always think about possibility of viral hepatitis. Think about liver abscess. Think about possibility of CCF, like a congestive cardiac failure. Those are the usual cause of tender hepatomegaly. So we know that how hepatitis usually present. In hepatitis, there is pre-icteric phase and icteric phase. In the pre-icteric phase or prodromal phase, patient gets like a mild constitutional symptom, mild fever, anorexia, nausea, maybe a little bit of vomiting, and upper abdominal discomfort. But when they become icteric phase, they start to get jaundice, dark urine, pale stool, and then tender hepatomegaly. Splenomegaly is not very common. can be there in 10% cases, but tender hepatomegaly with jaundice, we should think about hepatitis A initially. This is, you can see here, so if we have got a tender hepatomegaly, viral hepatitis, CCF, liver abscess, enteric fever, that will be our main differential. And you can also see from here that how we differentiate some of the liver function tests. If you have got a patient who has very high ALT, AST, especially more than 5 times of normal value, we think about hepatocellular hepatitis, which is likely to be viral hepatitis. If ALP or alkaline phosphatase increased, then we think about obstructive jaundice, maybe like obstructive jaundice due to biliary stone or bile duct stone. If it is GGT or gamma glutamyl transferase increased, then we think about alcohol-induced hepatitis or alcoholic cirrhosis. Okay. Good. Moving on to the next question. So a scenario of a patient with fall from bicycle 1 week ago and had a helmet fracture. No confusion, no amnesia, but patient has headache which increases with coughing. What is the most likely diagnosis? So 1 week ago, patient had a fall from bicycle, which was severe enough to cause the helmet fracture. Now patient did not have any confusion or amnesia, but at the moment having headache which increased with coughing. Headache which increased with coughing suggests possibility of raised intracranial pressure. So what are we thinking about? Intracranial hemorrhage, subarachnoid hemorrhage, epidural hematoma, subdural hematoma, or just a concussion. Now remember one thing. In here, as it happened 1 week ago, it's very unlikely it's a subarachnoid or intracranial hemorrhage. So forget these two. Concussion usually does not present in this way. Like they will not have headache which increases with coughing. It's either epidural hematoma or subdural hematoma. Now, which one is the top layer of meninges? So you have got first epidural space, then subdural space, right? When you have a helmet fracture, what do you think that it can damage? Because if it was just a fall and no helmet fracture, it might be just epidural hematoma. But when helmet get fractured and patient present a little bit late, we are mainly thinking about subdural hematoma. Okay, so the main thing is that if you get a patient who has a severe blow to the head, okay, like a very severe blow to the head, in that case, we think about possibility of subdural hematoma. If it's a mild, then we think about epidural hematoma. So you can see here, for epidural hematoma, a skull fracture can even happen from blunt trauma, which causes laceration of the arterial vessel. Fracture occurs most commonly in the region of temporal bone. In contrast to subdural hematoma, a tremendous force is usually required. In epidural hematoma, patient usually experience a brief period of loss of consciousness, followed by patient just become totally normal within hours. And then the patient again fall into unconsciousness, sometimes even into coma. So that's what we call as lucid interval. That typical lucid interval is usually the presentation for epidural hematoma. And in epidural hematoma, you get this kind of, see the biconvex shaped hemorrhage. That's what you get in the CT scan. Okay. Now, in case of subdural hematoma, head trauma causes rupture of the breathing veins. So, which means epidural hematoma happens because of rupture of the arteries, subdural hematoma because of breathing veins. The breathing veins are susceptible to rupture because the brain floats freely in CSF. Displacement of the brain can cause tearing at the point where breathing veins penetrate the dura. Subdural hematoma may occur with minor head trauma and in some instances even spontaneously. In contrast to epidural hematoma, changes may be very subacute or even chronic. In subdural hematoma, you normally get a finding like this, and this is called semi-lunar. Okay, so semi-lunar shadow in the CT scan like this, that is what we call as subdural hematoma. So I think I said you wrong thing. So what we normally say that if someone has got a very hard blow to the head, that's the time we think about extradural hematoma, because to rupture the artery, it needs tremendous force. Now, this patient actually sustained a helmet fracture. If someone sustained a helmet fracture, that means it's a tremendous force or a very huge force has been suffered by this patient. When there is such a force, we are mainly thinking about epidural or extradural hematoma. If it is a minor trauma, in minor trauma, we can think about subdural hematoma. Now, the confusion in here becomes that patient did not have any confusion, no amnesia. It might not be there in some cases. Some patients might not present to you. Some patient can present to you very immediately. So it does not depend on the presentation all the time, because subdural, epidural can present in a lot of ways, sometimes even totally asymptomatic. Sometimes patient can be in a coma as well. So based on the fact that this patient had a helmet fracture, which obviously a very huge force, we should think about possibility of epidural hematoma, not subdural hematoma. Okay. So the explanation is very simple. If a patient sustained a tremendous force, we are mainly thinking about epidural hematoma. Like a helmet fracture means, it means it's not like a helmet fracture. You can think that the helmet is damaged. Okay, it's not like a helmet fracture thing. It means that patient was riding a bicycle and obviously had a helmet on, and the helmet has got damaged or broken, you can say. When helmet is broken, it means that it was obviously a huge force. When such a huge force is there, we are mainly thinking about epidural or extradural hematoma. Okay. If it's a minor force, then we think about subdural hematoma. Moving on to genetics. Genetics is a very important topic for your exam, and you need to have a very good basic on it. Not too much, but at least the basic. Now, the good question is, Dr. Devi, the subdural is deep, but it's the vein which floats. So what happens is that even with a small slightest force, you can get rupture of those veins because it's floating. Whereas the meningeal artery, it is a little bit of fixed. It does not float like that because you don't have any CSF in there, right? In the epidural space. In subdural space, you have CSF and all of those things. So what happens is that the veins floats, and something which is floating, it is more easy to rupture rather than the fixed ones. So that's why normally we say that even sometimes elderly patient can just get a hit with a door and can end up having a subdural hematoma. So we always say that if an elderly patient coming to you with a recent onset of dementia, in that patient, we should always think about possibility of a chronic subdural hematoma. And in chronic subdural hematoma, patient can present to you months and months later. So the initial trauma was just maybe a little bit of trauma to the head. Maybe when patient opened the door, he got stuck with the door. Just a small blow can cause subdural hematoma. Okay. So mild trauma is subdural and heavy trauma is epidural. Okay. So the question of answer to that question, if an elderly patient come to you with a sudden onset of dementia, and then if you go in a little bit deeper, patients say, yes, I might have got stuck with a door maybe 3 months ago. In that case, what will you do? You should always order a CT or MRI of the brain, because that patient, the dementia is called vascular dementia, not Alzheimer dementia or something else. So that's also a very important question. Also, you will get this kind of question in your handbook, that if you get an elderly patient with a sudden onset dementia or forgetfulness, before thinking about anything, do a CT or MRI of the brain to rule out subdural hematoma. Okay. All right. Moving on to genetics. So I was saying that genetics is very important topic for your exam. You need to have a strong basic to answer those questions. And by strong basic, I don't mean that you will have to be very, very good in genetics. It's just the basic idea you should have. Let's talk about the basic of genetics so that you can understand it properly, because the question comes a little bit trickier way. Parents come to you that their son has hereditary spherocytosis. They want to know that what is the chance that his siblings will get the same disease, right? The first thing that we need to know, what is the hereditary transmission for this disease, or what is the genetic transmission for this disease? So is it an autosomal dominant? Is it an autosomal recessive? Or is it a, if you don't know that, you can't answer this question. So at least remember some of the important autosomal dominant recessive examples. So hereditary spherocytosis, yes, it's an autosomal dominant genetic inheritance. Very good, guys. So they're asking that what is the chance that his siblings will get the same disease? So we need to know that what is the transmission criteria for autosomal dominant inheritance. So 25% of his brothers, 50% of his sister, 50% of his brothers, 0% or 50% of his brothers and sisters. Now, to come to the answer of this question, we should know at least the basic thing. So let's find it out. When you get such a genetic question, first thing you should think that in case of autosomal dominant, let's say this is the X and Y is your father and X and X is mother. Now, don't think that this X and Y means that this is X-linked recessive thing that we are discussing. This is not X-linked recessive. You can use a lot of things. You can use AA and BB in here. So there's the thing. So one is dominant and another is recessive gene. In here, one dominant, one recessive. So when you think about autosomal dominant inheritance, you need just one affected gene to transmit to the next generation. Now let's say that in here, Y is the dominant gene, and this Y gene has got a mutated gene for hereditary spherocytosis. So how we are going to find out the inheritance? So there are 4 kind of pattern can happen. So one can be XX, another can be this X and this X, can be XY prime, can be this X and Y prime, right? So we have got this X and this X, we have got this X, and then XY prime and XY prime. So these are the 4 possibilities. So you can have 50% daughter, 50% son. Now, if you look at here, this 2 has not got any kind of defected gene. So this is normal. This one is same, also normal. XY prime has got one defected gene, and just if you get one defective gene, you have got the disease, which means this is a diseased patient. This one is also diseased. So in here, you have got 50% normal and 50% diseased. So this is the autosomal dominant criteria. Autosomal dominant can happen in either boys or daughters. Okay, that means it does not have any criteria that it will only happen to son or it will only happen to daughters. It can happen to anyone. So the thing in autosomal dominant is that 50% of son and daughter will be affected and 50% will be normal. Okay, so that's the autosomal dominant inheritance criteria. Now, if you come in here, they're asking that what is the chance that his siblings will get the same disease? So it's not like that, like one son has got the disease. That means in the next pregnancy, another one only get it. That means it does not mean it will be 25%. The thing is that every time a patient becomes pregnant, every pregnancy, there is a 50% chance that the children will be normal or 50% chance that either son or daughter will be affected. So what is the chance then? So your answer will be 50% of his brothers and sisters has got the chance of getting the same disease. Okay, so that's how the autosomal dominant inheritance happens. Did you guys get it? What's the confusion, Dr. Devi and Dr. Lubna? So is it the confusion with the X and X or what? Okay, yeah, I understand. Now, don't think that this X and X is female gene and this X and Y is male gene. It's not like that. It's about like, we're talking about just one dominant and one recessive kind of gene. Okay, those are not if you are thinking that this XY means it's a son and this XY means it's a son, it's not like that. You're thinking like a X-linked recessive pattern. Use the other things, like if you think it as AA and BB, then you will not be confused. Let's say this A is the affected gene. So then if you think in here, A prime B, then you have got A and B, you have got AB and BA prime, right? So if you see here, this one and this one is the defective gene, and this one is the normal gene. Okay. Now, in autosomal dominant, there is no son and daughter thing. Anyone can get it. That's the main thing that you should remember. So it's about the defective gene. It's not about the sex, because it's not a sex-linked recessive or it's not a sex-linked transmission. Okay. So it's about dominant gene. So the dominant gene, if it is affected, it will be transmitted to either son or daughter. So in here, you have got 50% normal child and 50% affected child. So the term we use is child, not any sex. Okay. Now, another thing, let's make it a little tricky because exactly same question come with autosomal recessive. Like they say in here that you have got a patient whose father and mother both thalassemia carrier. Okay. The question is asking what is the chance of their child to get the thalassemia measure. So what will happen that that autosomal recessive means two gene needs to be defected to have a full-blown disease, which is in contrary to the autosomal dominant. Autosomal dominant, if you have got only one defective gene, you get the disease. But to get the disease, you need two defective genes in case of autosomal recessive transmission. That's the main thing that you should remember. Now, again, let's say this is XY, this is XX. Now, again, don't think this is male and female X chromosomes, okay? So let's say that father is carrier. So let's say this gene is the carrier gene. Let's say this gene is the carrier gene. So mother has got one defective gene. That's why she is carrier, not thalassemia major. Father had got one defective gene. That's why he is also a carrier, but not major. So if we make in here, we have got X prime and X. We have got another X prime, X prime. Now let's think about Y and X, right? So XY and YX prime. So X prime, Y. So these are the four things that can happen, right? So you have got one defective gene here. That's a carrier. You have got one defective gene here. That's a carrier. Totally normal. So this is normal. Now this one, two defective gene. That means this is the diseased child, or this child can have thalassemia major. So what will be the percentage? You can see that 50% is carrier, 25% will be normal, and 25% will be diseased. So 25% of the child will have a chance to get the thalassemia major. Okay, is this clear, guys? Or you can say 1/4. See that if you understand genetics, it's so interesting, right? But if you don't understand it, this thing will make your brain gone totally. All good. So that's what we have understood. Now moving on. So in here you have got all the explanations, so that's fine. Moving on to the next question. So you have got a nurse who suffered needle stick injury at your ward. She had previous hepatitis B vaccine 10 years ago with positive serology. No booster taken after that. So 10 years ago, this nurse had hepatitis B vaccine with positive serology means that she had hepatitis antibody. Patients, now the source, which is the patient, HIV negative, HBsAg positive, and hepatitis C virus RNA positive, right? And they're asking, what will you do next? Now, this is a very commonly asked question for this year. That means that this is under occupational health exposure. So a nurse, they are very susceptible to get this kind of needle stick injury. Even doctors are also very susceptible. So in those situations, what are you going to do? Always we need to find out that who is the victim and who is the source. Source means in here, the victim is the nurse and source is the patient, right? You need to find out two things. That if the source has already some known blood-borne viruses, and the common blood-borne viruses are hepatitis B, hepatitis C, and HIV. So you need to find out that if the source already has something known, which you have already found from here, that HIV negative, hepatitis B positive, Now, it can be chronic, it can be acute, we don't know, right? But SBS AG positive, hepatitis C virus RNA positive. So we will be mainly thinking about these two, Hep B and Hep C, not about HIV. So what are you going to do next? This is a very tricky thing. You need to have a very, very good idea and make a note about it in somewhere so that you can just look at it and think about it, because it's very tricky. So are you going to give a prophylactic antiviral and tenofovir, only tenofovir? Are you going to repeat the nurse hepatitis C virus RNA after 3 weeks, or check the nurse Hep B antibody level? What do you think you want to do next? Okay, I understand that it is a very tough question for many of you. You need to have a guideline for this one. So let's go to the Australian Health Guideline. So this is called www.health.qld.gov.au. If you go to this form, if you go to this guideline, you should be able to find everything that you need for this pre and post exposure prophylaxis. Okay, so let's discuss. And if you get confused, let me know. Okay, and the thing is that this is a tough thing to remember, so you will not be able to just remember today. So you'll have to read it by yourself a couple of times, then you will get the idea. Now let's talk about hepatitis B. Yes, so I can share this one in your chat box. Okay, so if you have got a patient who is an exposed person, so we are mainly looking at the victim. So victim is the exposed person. What is the exposed person status? The first thing that we look for, if there is no prior history of hepatitis B antibody level more than 10. Now, hepatitis B antibody level more than 10 means patient is immune to Hep B. So, which means that either this patient never ever had hepatitis B vaccine, okay, or patient's immunity is not complete, maybe just taken one dose of vaccine, so patient did not develop antibody against it. The main thing is that if there is no history of immunity to hepatitis B, then what are you going to do? In such patient, you should offer them post-exposure prophylaxis. The post-exposure prophylaxis means start the patient with vaccine as well as immunoglobulin. So the vaccine in here, you will have to give 3 doses of vaccine because patient is not immune. So 3 doses of vaccine and a hepatitis B immunoglobulin will be the choice. And then you follow up the patients accordingly, which you don't need to remember. Now let's say you have got a patient who was previously vaccinated, like our patient. If you have got a patient who was previously vaccinated and current hepatitis B antibody level more than 10. So that's why it is important to check the hepatitis B antibody level to find out if they're immune to it. If they're immune, you don't need to give them any prophylaxis. So no treatment needed, just follow up. But let's say patient is vaccinated, but you have done the hepatitis B antibody level, which came below 10. In that case, what are you going to do? Normally, in those cases, they say that you don't need to treat the patient because previously, now it depends that currently that patient's hepatitis B antibody less than 10. But previously, if you can find out that previously their antibody level was more than 10, you don't need to treat them. But let's say you can't find that patient ever had a hepatitis B antibody level more than 10. And those patients are called vaccine non-responder. In those cases, you will give them 1 dose of immunoglobulin and 1 booster dose of hepatitis B. Now, make it easy. If you have got a patient whose current immunity more than 10, no treatment, current immunity less than 10, that means patient is not immune at the moment, offer them immunoglobulin and vaccine. Okay, that's the easiest way to remember. So that's how you are going to treat the hepatitis B. Now let's talk about this chart. This chart will help you to understand almost everything that you need. So first thing is that you have got a patient who was exposed to some blood or body fluid. You have done initial first aid. Then you assess risk, provide counseling, reassurance. If the source is known or likely to be HIV or hepatitis C virus positive, in those cases, you have to notify the infectious disease physician to think that if there is any need of any post-exposure prophylaxis. If the source is not known to be any infection, then you will request baseline blood from the exposed patient or exposed person for HIV antibody, hepatitis B antibody, and hepatitis C antibody. So if you have got source is not known or source is not known to be having any blood-borne viruses, in that case, you just request all the antibody level to the exposed person. You find out if the exposed person, hepatitis B antibody level more than 10. If yes, you don't need to do anything. If no, then you will have to give hepatitis B vaccine and immunoglobulin. This part we already know, right? Now, let's say the source is HIV positive or unknown. In those cases, you will have to repeat the HIV antibody in the exposed patient at 4 to 6 weeks and at 12 weeks to see that if the exposed person having any HIV positive or not. If source is hepatitis C virus positive or unknown, again, at baseline, you will check their antibody level and you will repeat it at 12 weeks and 6 months. The main thing is that normally we don't offer any post-exposure prophylaxis for a known hepatitis C virus positive or HIV positive source. You just follow them up. Okay, unless the patient is very high risk, usually no need of any post-exposure prophylaxis. That is also written in here if we see. You can look at this here. At this time, there is no prophylaxis proven to be effective for hepatitis C virus exposure. Immunoglobulin and antiviral agents are not recommended for post-exposure prophylaxis after exposure to hepatitis C virus positive blood. You just need to make follow-up of antibody and liver function test at 12 weeks and 6 months. Okay, is this clear, guys? I know it's a lot to take, but the basic is very same. That means the main thing that you are looking for is that are we able to give any hepatitis B prophylaxis? Okay, and to check that if the patient needs any hepatitis B prophylaxis is to check the hepatitis B antibody level. So this will be our answer in this case. Any question? it is confusing. So let's make a very clear thing. So if it's a hepatitis B, so what you normally need to find out, first of all, you know that who is the source and who is the victim. Find out if the source is positive for any infection. If you don't know the source, or if you are not aware that if the source has got any kind of infection, then take the blood from the exposed person for all the antibodies. Okay. In that time, you will get hepatitis B antibody positive. Let's say you have got hepatitis B antibody positive in the exposed patient. Even after Hep B antibody positive, still patient may not be immune. So check their immunity level. If the immunity is more than 10, that patient is immune to Hep B. In that case, you don't need to give them any hepatitis B prophylaxis. But if it is less than 10, in that patient, you will have to give them vaccine and immunoglobulin both. Okay. For other two, Hep C and HIV, there is no post-exposure prophylaxis. There is, but in very high risk situation, but in most of the time, there is no need. You just check the antibody level in the victim. Sometimes we also check the antibody level in the source if we don't know the source status. And then you just follow it up at 12 weeks and 6 months time. Yes, Dr. Shushmita, if patient is HIV, if the source is hepatitis C positive, then yes, you should check the antibody level of the victim to see that if that patient already has got hepatitis C positive in their blood or not. All good, guys? Again, the thing is that you should read this guideline, and then it will become much more clear, because it is a little bit tough and it needs a little bit of reading by yourself as well. Moving on to the next question. A lady comes to you with weakness of lower limbs. She drags her foot while walking. Dorsiflexion and plantar flexion is weak. Reflex are exaggerated. Equivocal plantar response. What is the diagnosis? Another tricky question is, you have got a patient with the weakness of lower limbs. So the lower limbs is weak. You have got that she's dragging her foot while walking. Dorsiflexion, plantar flexion is weak, right? Reflex exaggerated and equivocal plantar response. Now, what we say about motor neuron disease is that if you get a patient who has both upper and lower motor neuron type of feature in the same limb, that's the time you think about possibility of motor neuron disease or MND. So upper motor neuron type of feature is that their muscle weakness can be there, but they become spastic paraplegic. Whereas in lower motor neuron, it becomes flaccid paralysis and their tone becomes reduced, whereas muscle tone increased in upper motor neuron type of palsy. Fasciculation is a feature of lower motor. Reflex will be increased in upper motor, reduced in lower motor. Now, if you look at this question, you can see here that patient has got both limb paraplegia, right? So it's a paraplegic limbs. Their dorsiflexion, plantar flexion is weak. Reflex exaggerated. Reflex exaggerated means that it is upper motor neuron type of feature. But in upper motor neuron type of feature, what should be the plantar response? Plantar response should be extensor, or we call it Babinski sign positive. When plantar response is equivocal or flexor, there is a sign of lower motor neuron type of palsy. So what you have got is that in the same limb, you have got features of both upper motor and lower motor neuron type of lesion. And there is a very important diagnostic criteria for motor neuron disease. There are lots of type of MND, but the commonest type is this mixed pattern. Okay. So your answer should be motor neuron disease. Now let's say that, how about cervical spine MS? Now MS, before coming to MS, it's a motor neuron disease, which means only the motor neurons in your cerebral cortex or in the spinal cord or brain stem will be involved, no sensory problem. So in this case also you can see that patient sensation, they haven't said anything about it. So motor neuron disease, only the motor function will be affected. Whereas in MS, it can be motor problem, it can be sensory problem, okay? So if it is a cervical spine problem, not only the lower limb should be affected, but also the upper limb should be affected. So that's why we are not thinking about cervical spine myelopathy or multiple sclerosis. Now, why not spinal canal stenosis? Spinal canal stenosis should give you solely upper motor neuron type of lesion, not lower motor. Lesion in cerebral cortex. Now they have asked you diagnosis. They did not ask you what is the reason or what is the cause. If they would ask you what is the reason or where is the site of lesion, then you could choose this one. Because motor neuron disease is actually, there is a lesion in the cerebral cortex. But because the diagnosis they are asking, we are thinking about motor neuron disease. Okay, so the question pattern is also very important. Now look at this question. It's a similar question, but the type of question is different. You have got a 58-year-old man dragging left foot, reflex on the left lower limb are increased, plantar flexion, dorsiflexion weak ankle movement, but equivocal plantar reflex. Upper limb and face are normal. Where is the lesion, or what's the lesion site? Now, when they ask about lesion site, they're not asking about diagnosis. So is it a common peroneal nerve, cervical spinal cord, L5S1 nerve root, cerebral cortex, or brain stem? So what do you think? So you can easily see that brain stem should have some findings related to dysphagia. They could have some nystagmus, vertigo. Those features are brain stem problem. Then cervical spinal cord, it should have affected the upper limb, but upper limb is normal. So rule that out. Common peroneal nerve, it's a peripheral nerve. It should not cause any problem with the reflex. Okay, so peripheral nerve does not cause absence or presence of reflex. When reflex is there, it's not a peripheral nerve. So something in the root. Now, is it a L5S1 nerve root or is it a cerebral cortex? That's the question. What do you think? Now, tell me about what reflex will be involved in L5S1. Does L5 give you any reflex? They said in here, reflexes on the left lower limb are increased, which might be knee jerk, ankle jerk. L5 does not give you any reflex. No. The knee jerk is given by L3 and L4. The ankle jerk is given by S1. Okay. So when there is, if reflex on the left lower limb are increased, it cannot be L5. Okay. We will come to this L5S1 and common peroneal nerve in our tonight's session as well. And then you will understand it much better. But remember one thing, that L5S1 nerve root does not give you all the reflexes on the lower limb. And L5S1 nerve root issue should not increase the reflex. Okay, it can reduce the reflex, but should not increase the reflex. When reflexes are increased, it is something upper motor neuron type of problem. Okay, so upper motor neuron type of problem means something before the anterior horn of the spinal cord. Now, that's the tricky thing, that just because only one left limb is affected does not mean that it cannot be motor neuron disease. This is also a presentation of motor neuron disease, but it just affected one limb, which can be there also. Okay, so very tricky, right? Now, in this case, also you have got that patient reflex has been increased, like ankle and knee jerk increased, but plantar reflex is equivocal. So this patient also has got both upper and lower motor neuron type of palsy. So there is also a cerebral cortex is the lesion site. Okay. See that the tricky part, it can be quite easily missed if you are not, if you don't have this much idea. This idea is important. The nervous system makes you crazy in the exam. Okay. So only the important thing, that how you rule out things. Ruling out things is important. Like, let's say that how I can easily remove the unimportant thing. Cervical spinal cord is out because upper limb is not affected. Common peroneal nerve is a peripheral nerve, so it will not increase the reflex, so it's out. Brainstem should have some features of brainstem, so which is out. Now, between these two, you can easily think that L5S1, L5 nerve root should not increase knee jerk or ankle jerk because it does not give any jerk. Even if we think about S1, it can involve the ankle jerk, right? But how about the plantar reflex? Why the plantar reflex is equivocal? We don't know. So this patient is actually has got both upper motor and lower motor neuron type of feature in the left limb. And that is what we call as motor neuron disease. Not lower motor neuron type of feature, both upper and lower motor neuron type of feature. Because it can affect, this motor neuron disease can affect all the motor neurons, even the motor neurons in your muscle. So when the muscle neurons will be affected, you can get lower motor neuron type of palsy. So if you think about all the upper motor and lower motor lesions, you see that the tract comes from the cerebral cortex, and then it goes down and down. Then it comes to the spinal cord. Then you have got the anterior horn cell of the spinal cord, right? Where it gets connected, and then it goes to the specific muscles. So all the motor neurons in your body can get affected, which means that it can affect your cerebral cortex. It can affect this side also. So that's how it causes both upper and lower motor neuron type of palsy. Now, have you guys got an idea about this homunculus? This is how we think that I know that you are thinking that how only left lower limb is affected from the cerebral cortex. The homunculus is a thing that your cerebral cortex, the specific part of the cortex has some specific features. Like if you see here, this part of the cerebral cortex is supposed to control your face. This part is your arm. This part is your leg. This part is your trunk and the body. So if someone has got problem only in this side, okay, then only this left lower limb or right lower limb can be affected. Others can be totally normal. So that's how only one part can get affected as well. Same with a stroke patient, right? So that's how it usually happens. Okay, so let's take a 5-minute break now, and then we will discuss some more interesting topics. Okay, 5-minute break. Thank you. All right, everyone, let's start again. So you have got another question. So two tiny magnets aspirated in a 5-year-old came to ED after 4 hours. Immediate X-ray is done. Magnet is in small intestine. And after 6 hours, the magnet is still in the same position. What do you want to do next? So the main thing is that it's a 5-year-old in the emergency department. You have done a X-ray after 4 hours. Okay, magnet you have found in the small intestine. Then after 6 hours, you did another X-ray, but the two tiny magnet is still in the same position. That means it hasn't passed. What do you want to do next? Immediate laxatives, immediate surgery, do nothing, serial X-ray, or immediate endoscopic removal. Let's have a look. So what are the high-risk foreign bodies? The high-risk foreign body, obviously button battery is the highest risk. Any large object which is more than 6 centimeter long or wider than more than 2.5 centimeter, magnet plus metal object, more than one magnet, any lead-based object, or if someone has got abnormal GI tract for previous surgery or TOF. Now, this is the guideline that we follow. Let's say you have got an initial presentation with a witnessed magnet ingestion. First thing we look at, is it a symptomatic patient or asymptomatic? If it's a symptomatic patient, removal is the main thing. So either you can remove by endoscopy or surgery. It depends on the location. If it is endoscopically available, you can remove it by endoscopy. Like if it is in the esophagus, then you can remove by endoscopy. But if it is in the small intestine, you might need to do the surgery, right? Then for asymptomatic, is it a single piece of magnet or multiple piece? For single piece, you can observe as outpatient by doing a serial X-ray daily. But you will have to confirm passage of this magnet out of the body by X-ray. If there is no progression in 24 hours, consider that patient might have got more than one piece and consider doing a lateral X-ray to find that out. And you will need to remove that anyway. So no progression after 1 day, even if it's a single piece, you need to remove it. If it is confirmed passage by the X-ray, then you don't need to do anything, you can discharge the patient. Now, multiple pieces, you should admit for observation with a serial X-ray every 4 to 6 hours. If it is passed, then discharge. If no progression on X-ray for 4 to 6 hours, then again removal is indicated. So what do you think in this case you will do? It's a multiple piece magnet, right? Small intestine. After 6 hours, magnet is still in the same position. So what do you want to do? We can't do endoscopy. Most likely, if it is like, let's say in the jejunum ileum, it will not be like endoscopy would not be a best idea in those cases. If it is near to that, then we can do it, especially even if it's in the stomach, then endoscopy would be a very good idea. In this case, laparotomy or surgery will be the choice. Okay, clear? So these are the important things that come in the exam. If you just know this chart, you can easily answer it. But if you don't know it, it will be very tricky in the exam. So that's where you need a guidance where you can see that what are the important things to be remembered. Otherwise, like these are not in your JM. So you'll have to just find it out from the Australian guidelines, right? So that's the tricky part for this AMC exam. There is a lot of guidelines to be read about. It's not just focused on only one book or only one thing. It's a lot of things from where you will have to collect your knowledge. Okay. Now let's move on to another important topic called CVS risk assessment. CVS risk assessment is a very important topic for exam. Now, I don't know that if you guys are aware of one thing is that in exam, the questions have different marks. Some questions carry 2 marks, some questions 4, 6, 8, 10. The 10 marks, if you can get those things right, it becomes very easy for you to pass. But those 10-mark questions are also very hard and time consuming. CVD risk assessment is one of those questions. Okay, but no one knows which question carries what kind of mark. So some of the questions are mastery questions, which means that you are supposed to know that. If you don't get those mastery questions right, there is a chance that you might fail the exam. And again, no one knows which one is mastery questions. Throughout the experience that we have gathered, it means that the mastery questions are questions that come frequently in exam. And those are very important, very common things that you should know. So those are mastery questions. Like there are questions about back pain, there are questions about prostate, there are questions about arterial blood gas, there are questions about oliguria after surgery, questions about postoperative fever. So we know about the important questions, and we feel that those are most likely the mastery questions because those questions are very important, come very frequently in exam. So you need to know these kind of things so that you don't miss those things. Missing mastery questions is not a good idea. So let's talk about one of these important topics, which is CVS risk assessment. So you have got a 64-year-old smoker, women, blood pressure 135/68. Cholesterol HDL ratio is 6.6 to 1. You have got a chart like this. And they are asking what is this patient 5-yearly CVD risk. So when they ask about CVD risk, they give you everything that you need to use in the chart. Okay. So the main thing that you need is that what is the age of the patient? What is the sex of the patient? Is it a smoker or non-smoker? Is it a diabetic or non-diabetic? What is the systolic blood pressure? And what is the cholesterol level? So these are the important things that you will need for this chart. If you look at this chart, you can see this is for people without diabetes. This is women, this is men. Non-smoker is smoker. And in here you can see the age. Now find out where your patient falls. 64-year-old is smoker women. So this is a smoker. This is the 64 group. So your patient falls in this box. So you will only look in this box, nothing else. After that, no, in Australia, we use 5-yearly risk assessment. It's not WHO risk assessment that we use. We use the Australian risk assessment, okay, which is the Heart Foundation risk assessment. Now, in the y-axis, you can see the systolic blood pressure. And in the x-axis, you can see the total cholesterol HDL ratio. So these two you will need. Before you move on, you need to first know that You can see this marking 120, 140, 160, 179. So this one box, the question is, what is the highest number you can keep in this number or in this box? So what is the highest number which will fall in this box? Is it 120? Is it 130? What? The answer is that it's not 120, up to 129. Okay, up to 129, or just make it as a whole, up to 130. You will think about this box. Up to 140 this box, 170 this box. So just add 10. This is where people get confused a lot in the exam. Okay, this is clear, guys. So this box 130, this is 150, this is 170. Now come to the next part, cholesterol HDL ratio. So you can see 4, 5, 6, 7, 8. Now this box, it's not 4 that you can put here. The highest number in here that you can fall is 4.5. This here 5.5, 6.5, 7.5, 8.5. Okay. So if you remember this two part, it becomes very easy. Is this too clear for everyone? Because if you are not, then just let me know. Otherwise, we will not be able to repeat it again, the same thing. Okay, so if you just let me know that if these two are clear, then we will move forward. No problem, good. Now you find out 135 is the systolic blood pressure, right? So find out where 135 will fall. So we know that up to 130 is this box. So this box will be 130, right? So 135, we know that this is the box where we will be looking at. Now we come to 6.6 is our cholesterol. So 6.6, we know that up to 4.5 is this box, 5.5 is this box, 6.5 is this box. So 6.6 will fall in this box, right? Now if you move forward, so this is our main box, or this is our risk assessment box for this patient. So YOLO. Now in exam, this chart will be given, and also they will write that what YOLO box means, what's green box means, blue box and red box means. Okay, so if I show you that, this is the chart, you can see red means more than 30%. Then these are 25 to 29, 20 to 24. Our patient was this YOLO, right? So it's 16 to 19%. So you'll just need to choose this from the option. Okay, so that's your CVD risk assessment. And that's how you can tell them that what is their risk. Are they high risk, moderate risk, or severe risk? Red means severe risk. Okay, so that's all about your CVD risk assessment. Moving on, any question, guys? You guys understood? Dr. Fayaz, everything clear? Good, very good. Moving on, a patient which has been illustrated here has presented after sustaining a stab wound to the back of the left forearm in a pub brawl. He is trying to straighten his fingers on command. So this these fingers, you can see that the right wrist and fingers he is able to extend, but is not able to extend the fingers of the left hand, right? But he's able to do the extension of the wrist. So they're asking which of the following nerve is most likely to have been injured. Now, the nervous system is very tricky, as I said multiple times. You need to have a very clear-cut idea about these nerves. Is it a median nerve, ulnar nerve, radial nerve, posterior interosseous nerve, or anterior interosseous nerve which has got injured? Now, time to time, what happened, Dr. Roha, is that in exam, most of the time they give you this color of the box, but sometimes they don't. So it's a good idea to remember it if you can. But I have seen that most of the time it is given. And this chart, you can get it from the link that we have given in here. Okay, you can get it in saheart.com.au. Okay, moving on. So what do you think that this patient has got problem? Median nerve, ulnar nerve, radial nerve, posterior interosseous or anterior interosseous nerve? Let us discuss about it and then come back. So we will discuss about radial nerve anatomy today, not median or ulnar nerve, but all of them are pretty important for exam, especially median nerve and radial nerve. So let's talk about radial nerve course. So radial nerve, you can see it starts from the brachial plexus. Then it turns around the spiral groove of humerus. And then it comes forward around the elbow joint. It divides into two branches. One is called posterior interosseous nerve. Another is called superficial radial nerve. The anterior interosseous nerve is a branch of median nerve, and posterior interosseous nerve is a branch of radial nerve. Okay, so you know about the course now. Now, this radial nerve can be injured anywhere in its trunk, right? So we need to know that if it is injured in the axillary region, what will be the presentation? If it is injured in the elbow, what will be the presentation? So that's what you need to know. So let's say if injury of the radial nerve happened at the axilla, what will be the presentation? Even before that, you need to remember that main function of radial nerve is it helps you to do the extension. So extension of the forearm, extension of the hand, extension of the wrist, extension of the finger. So every extension that you can do is done by the radial nerve. So extension of forearm, extension of the wrist, extension of the fingers. What is the sensory function? Radial nerve supplies the dorsum of your hand, not the palmar aspect. Palmar aspect is supplied by median nerve and ulnar nerve, whereas 3.5 fingers will be supplied by the radial nerve, but it will be supplied in the dorsal aspect. Now it is a little bit wrong in here. It should be 3.5. So this one is 1, 2, 3.5. So 3.5 fingers in the dorsal aspect of the hand will be supplied by the radial nerve. So if there is a radial nerve injury, you will get loss of sensation in thumb, in index finger, middle finger, and half of the ring finger. Okay. Now come to the presentation. If there is an injury of radial nerve around the axilla, there can be motor or sensory deficit, because it's in the uppermost part of your radial nerve. That means every function of the radial nerve will be damaged. So which means that there will be loss of extension of forearm, loss of extension of the wrist and fingers. Okay. Sensory deficit, again, there will be loss of sensation of the arm, forearm, and those 3.5 fingers. Okay. So that's your injury at the axilla. Now let's say injury at the mid-arm. Mid-arm means if someone has got a fracture of the humerus, like if you see here, this radial groove of humerus or mid shaft of the humerus, very prone to get fracture. So if someone has got fracture here, radial nerve can be injured. So what will be the feature at that time? More or less similar to axilla, but only thing will be the difference is in the sensory loss. The motor loss will be same. The only loss of sensation here will be these 3.5 fingers, not in the arm or forearm. So basically, if you have got injury at the axillary region, loss of sensation in the arm, forearm, and 3.5 fingers. If you have got injury here, the loss of sensation will be mainly around these 3.5 fingers. Okay, maybe a little bit in the forearm and these 3.5 fingers. Obviously not the arm. After that, if injury happens just below the elbow, which is also very prone to get injured. If just below the elbow, then mainly the injury happens to the posterior interosseous nerve. Posterior interosseous nerve is mainly a motor nerve. Okay, that means it just gives you motor function, no sensory function. So only loss of motor function will be loss of extension of the fingers. So if we come here, so if you have got a patient who has got injury below to the elbow, and it has only injured the posterior interosseous nerve, then only problem will be loss of extension of the fingers, no sensory loss. How about at distal forearm or around the wrist joint? Stabbing or laceration of the forearm resulting in injury to the superficial branch of the radial nerve, which is entirely sensory, which means that if you have got injury to the distal forearm, like let's say around this area, you have only got superficial radial nerve here, which is basically a sensory nerve, no motor branch. So only finding will be loss of sensation in these 3.5 fingers. Okay. Now, based on our, what do you think this patient has got? Obviously not a median nerve, ulnar nerve, or anterior interosseous nerve. The option is between C and D. What will you choose? This is a tricky thing because both of these options are correct. But in exam, remember one thing, that always choose the most definitive one. Because in here, obviously posterior interosseous nerve is a branch of radial nerve. But if you need to choose, you should choose the exact one. So we know that posterior interosseous nerve only helps with finger extension. And our patient only problem is that he's not able to straighten his fingers, which means that he has injured the posterior interosseous nerve. Okay, clear? Now, another nerve. So, you guys understanding me? Any problem? Is it too much to take for one class? I know it is tricky things, but these are very, very important knowledge that you are getting today, and you can use this in almost a lot of question solvations. Having a good idea about these topics makes it easier for you. So you have got a 64-year-old woman. So 64-year-old woman complains of dragging her right foot and numbness and paresthesia in that leg. On examination, there is foot drop with weakness of dorsiflexion, inversion, and eversion of the ankle. The reflexes are normal. and there is loss of appreciation of pinprick on the outer side of the lower leg. A lesion of which one of the following nerve root or nerve is most likely the cause of her presentation? So you've got a 64-year-old woman who is dragging her right foot and numbness and paresthesia in that leg. There is foot drop, weakness of dorsiflexion, inversion, and eversion. Reflex normal. See that if it is nerve root or peripheral nerve problem, reflex will be normal. There is loss of appreciation of pinprick on the outer side of the lower leg. Let's discuss one by one. You need to have a very good idea to answer this kind of questions. First of all, let's talk about common peroneal nerve and their branches. Common peroneal nerve is a branch of sciatic nerve. So if we look at here, see this image. So sciatic nerve comes from your lumbosacral plexus. The branch of sciatic nerve is common peroneal nerve and tibial nerve. The common peroneal nerve around the head of the fibula, it just comes forward like this and divides into two branches. The two branches name is superficial peroneal nerve and deep peroneal nerve. And the other branch of the sciatic nerve is tibial nerve, which goes behind your leg and supplies the posterior aspect of your leg. So your anterior portion of the leg is supplied by common peroneal nerve. Posterior part of the leg is supplied by tibial nerve. Common peroneal nerve, because it comes forward around the head of the fibula. Sometimes if there is a fibular fracture, common peroneal nerve can be injured. Or if your work includes lots of picking or squatting, it can also damage the common peroneal nerve. Common peroneal nerve divides into two branches, superficial peroneal nerve and deep peroneal nerve. Okay. Now, these are all peripheral nerves, which means that it will not damage, it will not cause any trouble with the reflex. So reflex will be normal. So we know that common peroneal nerve divides into superficial peroneal nerve and deep peroneal nerve. Now, what is their motor function? The motor function you can easily remember by ED. E means eversion, D means dorsiflexion. So common peroneal nerve mainly helps with eversion and dorsiflexion of the ankle. Now, remember deep peroneal nerve by dorsiflexion, D for D. So dorsiflexion will be given by deep peroneal nerve and eversion will be given by superficial peroneal nerve. Very easy, right? If you can remember. So common peroneal nerve does eversion and dorsiflexion, whereas eversion will be done by superficial peroneal nerve and dorsiflexion by deep peroneal nerve. Okay, that's the motor function. Reflex normal, sensory function will be, it supplies the whole anterior portion of your leg, this common peroneal nerve. How about their branches? If you look at this picture, superficial peroneal nerve supplies the whole anterior portion of the leg, everything, except this part, the yellow part, which is your between the space between first and second toe. This interdigital space or first interdigital space, this is the only space which will be supplied by the deep peroneal nerve. Okay, so that's their motor function and sensory function. Is this clear, guys? It's clear, guys? Yeah, great. Now, how about L4 and L5 nerve root? If you look at here, first of all, your dermatome is also important to remember. So L2 is usually the anterior portion of the thigh. L3 is around the knee joint, this part. L4 is the medial aspect, or you can say the inner aspect of your leg is L4. Outer or lateral aspect is L5. And the lateral aspect of the foot is S1, and also the sole of the foot, S1. Now, if you look at here, loss of appreciation of pinprick on the outer side of the lower leg. So which dermatome is the outer side of the lower leg? L5, right? Good. So L5 is the outer side of the lower leg. Your knee jerk will be given by L3, L4, ankle jerk by S1. L5 does not give any reflex, which also in here we can see that this patient's reflex is normal. So we have got two findings. What is the motor function of L5? L5 gives three kind of function: dorsiflexion, eversion, and inversion, which also we have found here that this patient having weakness of dorsiflexion, inversion, eversion. The foot drop happens if someone is unable to do dorsiflexion. Okay, so based on all of it, what do you think your answer is? Which nerve root has been damaged? L5 nerve root. Okay, why not L4? Because L4 would affect the knee jerk. L4, the loss of sensation would be in the inner aspect. Superficial peroneal nerve, because superficial peroneal nerve only helps with eversion, not the others. Tibial nerve helps with plantar flexion. And sciatic nerve, if everything is like in sciatic nerve damage, everything will be lost. Okay, but usually sciatic nerve, the symptoms becomes kind of a shooting pain coming from the lower back and going down to the foot. That's how the sciatic nerve presentation happens. It does not usually present with a foot drop. If there is a foot drop, think about either it's a L4, L5 nerve root problem or it's a common peroneal problem. Okay, clear everyone? Any questions? All good. I think like let's finish it here tonight because we have already discussed a lot. We have a lot of other things to discuss, but that's fine. We can always discuss it in your class. Okay, it's fine. I hope that you guys enjoyed the session, and you can see that how usually we solve the questions. It's just not just saying that this is the answer of the question. It's all about discussing the question in detail so that you understand it. And in that case, you learn a lot. It's just not just the question that you're learning the theory as well. So that's how our classes usually happens, so that you get an extensive idea about it. Now, let us discuss a little bit about the course, because I know that a lot of you have a lot of confusions about it, right? So let me just open your course detail and then we can just discuss about it from here. Just 1 second. If you have any questions, you can also ask it after I discuss about it. Okay. Now, this is our official website. If you go through this firstaidamc.com, you should be able to get it. If you go to our courses, this is the course that you are looking for, 5 months MCQ course. You should be able to get the whole idea about the classes. So you understand that our course started from 6th of December. Today is the first class of that course. Okay, that means you are actually just getting our classes, but the initial 2 weeks is free for everyone, just for everyone to see how we take classes. We don't offer just one class and ask you to enroll. We offer you 2 weeks, learn about us, and if you think it is important for you, then only you join. This is a 5 months course which has 3 days class. The classes usually we do on Sunday, Tuesday, and Wednesday at around 8 or 8:30 p.m. Sydney time. Classes are usually 2 to 2.5 hours. We will cover almost everything that you need to pass this exam. There is nothing that you will need extra apart from the course. So we will do the full theory, mainly from JM 8th edition, something from Kaplan Step 2 and other Australian guideline. After every system, like let's say we finished cardiology, you will get theory-based practice test in your portal or in our software. And you will be able to practice questions just like AMC exam in our portal. So let's say you finish cardiology, and then after that, you can just appear the cardiology mock exam. Just like that, we have all other theory mock tests. Then you get subjective sample question practice. Subjective sample question practice means that we take a theory class, and after that theory class, we do some question solution on that theory. Like you will get it in this 2 weeks free session where we will finish cardiology and we will do some cardiology question solve. So that's called subjective sample question practice. Now we also discuss recent sample question discussion. You will get 4 years recent sample question discussion, but obviously we will not discuss 2018 questions. We will discuss the recent ones. You get 1 class every week on recent sample question solved. But in our portal, you have got 4 to 5 years questions, all solved, everything also in a video recorded sessions with the past classes. So those questions are sample questions, which means that this will help you to learn how to solve questions and how the questions can appear in the exam. Okay. When you do those sample question discussion, usually you do it with another mentor called Dr. Rabia, who will also take 2 classes in your free 2-week session. I'm sure you will love her as well, because a lot of our students is still doing her classes even after finishing the course. So recent sample question mock test. Once you finish this sample question discussion, then you can also do some mock test on those questions. In your portal, you will get 30 subjective mock test, 15 to 20 sample question mock test. Now it's even more than that. And also 3 to 5 full mock test, which is 150 question, exactly same like your AMC MCQ exam. QBank free of charge. We also take extra classes on ECG, CT scan, X-ray, CTG, STAT, ethics, and fundoscopy. Ethics, normally we did not used to take it in our previous session, but from your course, ethics is also added. Recordings and notes. You will get the notes until you pass the exam. You will get the class recordings even after finishing the course. Usually 10 months, total 10 months class recording will be there in your portal. But most of the time you will be able to appear and pass the exam within 10 months. And also all the books that you need for the exam will be given to you, just a soft copy, not the hard copy. You can see the course fee is very minimal, which is $499 Australian dollar. And that's, apart from that, you also get a little bit of classes on registration and how to take job offers and all of those sessions you will also get as part of the course. Okay. Yes, you can do mock test more than once. Those are unlimited. You can add our classes on CPD dashboard if you are a member of RSCGP or ACROM. So if you are a member of any of those colleges, you can add our classes in your as your CPD. There was no class taken on 6th of December. This is the first class. Now the payment is all online. So you can always inbox us. We can send you an invoice, or you can also pay the amount through our portal or through the software. You can always pay from there as well. So RSCGP or ACROM. So these are the two colleges. If you are a member of those, you can even take membership with a very minimal fee from them. And then you can add our classes as your CPD. Any other question, guys? I hope almost every question has been answered. The offline opportunity, Dr. Humaira, is that this is a recorded session, right? So if you're not able to join the live session, you can always listen to our recorded session. Almost half of our students do that, because what happens is that many times you are working in your country, the time I know that in some other country at the moment, it's maybe even evening or afternoon. So you must be working at this hour. So that's fine. You can always just listen to the class recording. Class recordings are exactly same like the class. But I always encourage to come in the live session because you get to ask question. Okay, so but still, if it is not possible, then the recording is there. You can always finish the course as offline just by going through everything in the portal. Yes, you don't need AMC exam to become RSCGP member. You can be a RSCGP member by IMG, who is practicing outside of Australia. And Dr. Lubna, it was not like we haven't taken the December 6th class. It's usually we take 1 week to add everything in your portal. And that's usually we're transferring everything to your portal, and it takes some time. So usually we take that time for that. But don't worry on those things, because everything that is included in the course will be finished. That's actually our part. We will do it anyway. Yes, Dr. Devi, what's the question? There should be documents in the dashboard, Dr. Inia. Just send me an inbox right now and just send me your email. I will check it from the portal. What happened should be there. We have added all the theory notes in your portal already. How to pay from Bangladesh. Now, the thing is that if you are paying from any country, it's the same thing. You will have to pay as an online, because we don't have any other methods of payment. Okay, which means that you can talk with your bank for online payment. Okay. Or sometimes what I have found that if you don't have that online card, you can always ask someone in Australia or USA, if you have got any friends, any relative, they can pay on behalf of you, and you can just give them the amount. That's also some of our students does if you have any trouble. Yes, you will get that recording of the lecture of that pathway. Yeah, I think it is not added in your portal yet. We will ask the team to add that. That's fine. And try to use the portal with laptop or desktop. It becomes easier. Okay, guys, so that should be all for tonight. We will again have our next class. I think you have got your schedule. So next class will be on 18th, and we will start cardiology class. Okay. Thank you all. It was nice to discuss with you. Have a good night.